with this one. So anyway, so the point is that Lauren presented their approach to patients with lung disease. I think her approach was very scientific. It was a result of a consensus conference at their center, and it was published a few years ago. In Cincinnati, we are not that organized. Grant and I, we sat down and kind of mapped what we would do in our center and kind of circulated that particular proposal among our colleagues. And that's a result of that sort of consensus that was not formal. So I still would like to be able to point to the, is it working this one? Yeah, so first of all, so let's start with the patients with newly diagnosed systemic juvenile idiopathic arthritis. We don't care about the HLH genotype. We immediately start those patients on the biologics, but we do assess baseline levels of IL-18 and CXCL9 and follow them at least every 3 months. And we now do think that the genotyping for HLA-DR115 alleles is a good idea. But from the very beginning, we look for the presence of various risk factors in our new patients. First of all, we look at the age of onset. Most of these kids with a lung disease present with the first signs of the disease before their second birthday. Most of these kids have predominantly systemic features, very little arthritis, if any. As we discussed before, the vast majority of them have recurrent or smoldering macrophage activation syndrome. Certainly, if we observe this anaphylactoid reaction to Actemra in particular, we are worried. We are looking at the presence of peripheral eosinophilia, pruritic rash. We're looking at the levels of IL-18. And we are worried about patients who have persistently elevated or increasing levels of CXCL9, and certainly the presence of the risk allele is one of the major risk factors. So we assess for the presence of those factors, and if at least 3 risk factors are present, we immediately get our pulmonary colleagues involved. And we start with just a very basic assessment of the lung function. Again, what we do depends. Yes. Sorry, it should be there, absolutely. In Cincinnati, we're around 16% right now, correct? In our cohort of patients with a lung disease, 16% of our patients have trisomy. Yeah, it's a good point, we missed that. But anyway, the point is that if at least 3 factors are present, we get our pulmonary colleagues involved as soon as possible and start with some kind of a functional assessment of the lung function. And what we do depends on the age. If a kid is very, very young, probably the only thing we could do is a chest X-ray, baseline chest X-ray, as well as baseline continuous overnight pulse oximetry. And the overnight pulse oximetry allows us to assess sort of the average oxygen saturation level for the night. It will give us the idea how many episodes of desaturation happen, how much time our patients spend in that state. So we have some actually real numbers that we could follow over time. Yes?
Do you have, because this is a new thing for me at least as a rheumatologist, I imagine your pulmonary colleagues have norms for that kind of data?
Yes. Yes, they do have norms, although I guess it's not the norms that are important. I think it's the trend. So really, you want to establish the baseline numbers, and then you will be able to follow them over time. So if the kids are a bit older, we actually do like the 7-minute walk test, as well as PFTs in more mature patients. If any concerning findings are present, we proceed with a high-resolution chest CT. Although I think, particularly listening to Paul yesterday, I think we are reducing the threshold for the high-resolution chest CT. And if we have more than 3, quite a few risk factors, we probably will go ahead with a high-resolution chest CT, even if the functional assessment does not seem to be abnormal. Then we look at the high-resolution chest CT finding. And the question is, do we see sort of those classical features of SGI-associated lung disease? But when I say classical features, I specifically refer to sort of very bizarre, it's actually not pleural thickening, it's a wrong term, I think. It's subpleural consolidation lung parenchyma. We're looking for intralobular sepal thickening, ground glass opacities, and if the pattern is relatively typical, then we don't even consider a biopsy. However, if the pattern is not typical, if we pick up some abnormal, some other strange features that do not fit in that list, then we typically either consider a biopsy or at least BAL, particularly if infection is suspected. Then we certainly do all the workup for infection. That would include evaluation of the bronchial alveolar lavage fluid. Now, let's say we, yeah.
Sorry, I wanted to ask you about the timeline for the CT scan. I've had a lot of experience with patients when they are somewhat acute in their diagnosis and may have a coexisting other infection, which then subsequently requires us to do another CT scan to clear
Yes, exactly
the one that
right.
they might
So
have. Do
typically,
you tend to wait a little bit?
Yes, exactly right.
Yeah.
If there is an acute infection, clearly an acute infection, we would not do a high-resolution chest CT scan at that time. We would just limit it just to regular X-rays. Grant, correct me wrong, Chris usually wants to wait at least a couple of months, right, after the resolution of infection before we proceed with a high-resolution chest CT with the purpose to look for this lung disease. Yeah, at least a couple of months.
Some space a little bit after.
Yeah, absolutely. Yeah, we would not do it during an acute infection. A couple of things. I would like to step back to sort of the beginning of this algorithm. So let's say we have a newly diagnosed patient who does not have significant numbers of risk factors. We still watch those patients. We watch for signs of lung disease like clubbing, tachypnea, persistent dry cough. And another thing I would like to stress how important it is the fact if a patient is diagnosed with pneumonia and you treat that patient with antibiotics, don't forget to repeat the chest X-rays and make sure that the pneumonia is gone, because we've seen quite a few patients with ground for a second opinion who were diagnosed initially with pneumonia. They did a little bit better on antibiotics, no follow-up X-rays, and sort of that initial stage of the lung disease in those patients was missed. So it's very critical if you suspect pneumonia, if you diagnose pneumonia on the initial chest X-ray, please follow up and make sure that the findings, that the change is resolved. Now going back, so let's say we are at the time, that point when the diagnosis of the lung disease is clear. So how do we handle the lung disease from there? So first of all, the question about the biologics. We continue biologics if they are effective for the control of the underlying systemic juvenile idiopathic arthritis. Because what we see in these patients is that if the disease is inactive, the lung disease will is active, the lung disease will progress. We are very much worried about the episodes of MAS in these patients. With each episode of MAS, we see additional damage to the lungs that becomes irreversible. So if we stop biologics too quickly, and as you heard yesterday and today, many patients do flare with MAS, and that always would produce additional damage, irreversible damage to the lung. We need to avoid it as much as possible. So from that perspective, we think it's important to continue the biologics. But we do add some kind of a synthetic DMARDs that would target T cells, could be MMF. I think JAK inhibitors are becoming more popular. I think the Boston group at some point was in favor of mTOR inhibitors, although I'm not sure how much they help. We certainly choose usually between MMF and JAK inhibitors. Consider corticosteroids. I think it may be helpful. We do stop biologics if they are only marginally effective for the control of the underlying disease. And then we also focus on aggressive PJP prophylaxis as well. We typically would start azithromycin, first of all for prophylaxis of infection, but also our pulmonary colleagues believe that the azithromycin would have some anti-inflammatory effect in the lungs in this patient population. And then, as we discussed yesterday, if the disease continues to progress, then certainly we get our BMT colleagues involved as early as possible. Again, there is very little science very little data to support this particular approach. It's just how we sat down with Grant and came up with this plan. And I would like to hear your comments on that.
Alexei, you have, if you meet your threshold of 3, it's an additive thing, but probably some of those are more relevant than others.
Yeah.
And specifically, I want to know in your cohort, what percentage of systemic JA lung disease have never had MAS?
Grant, 20?
Yeah, 15 to 20.
15-20%, yes.
Sorry, Alexei, just a very quick question. How many of your patients received a diagnosis of lung disease at really onset of systemic GIA?
I don't think any.
Okay, so the idea of doing a chest CT at baseline is to have a baseline point in any of the risk factors.
I'm not proposing to do
I hear.
anything. I would do a regular X-ray, right? But chiefly,
Okay.
I'm not advocating for
Okay.
chest CT at disease onset.
So do you have a?
But I think we don't know. We don't know because we haven't looked. We don't know that the chest CTs are normal at baseline.
Like.
I think we don't know that their chest CTs are normal at baseline because we've never looked. We've never done that. We want to. So we wrote a grant to do ultrasound, chest ultrasound, xenon MRIs if we can, and then CTs. And we're going to try to fight that fight with the IRB to say, let's do a research-based CT on all of these kids because the risk is relatively low and we don't know. So.
So in patient with high risk factors?
Yes.
Okay.
I have to say that when we discuss this specifically with patients, with the parents, Rashmi confirmed, the parents have a very, very low threshold for actually getting a higher resolution chest CT. They certainly would be very supportive of doing it sooner. And Paul, I'm sure that's your approach as well, correct?
Oh, sorry.
Yeah, I would have a low threshold for doing it. It's such a rare disease and a serious complication. It's really not such a big deal, I think. But Alexei, my question was, once into lung disease is established, how often do you repeat the CT to monitor?
So really we are trying not to repeat high resolution chest CT more than 1 year. Grant, correct me if I'm wrong, unless. But in the meantime, we keep monitoring all these functional parameters, right? And if we see any kind of worsening, we might consider a high resolution chest CT sooner than that. But our general approach should do it once a year.
I think we do it a little more frequently because I think we don't know if the child is going to be a breastfeeder or not.
Yeah, Paul, what's your approach? You do it more frequently as well, I hear, right?
I would get another one 3 months later.
3 months later?
And then see where.
That's about what we,
Because it's the young.
especially if it's concerned.
You keep that one.
Sorry.
It's because it's the issue. It's the very young patients. So we found completely normal overnight saturations. We often have to do fitness to fly tests, so controlled hypoxia. It's completely normal, and yet the clubbing is worse and the CT is worse when you repeat it. So all of these things are good, but I just don't think they're sensitive enough. So an early repeat CT.
Every 3 months?
Not every 3 months. I'm saying 3 months after the first one.
And then?
And then take a view, just make it up for your individual patient.
It's about a situation that I've seen in a few patients where they end up getting a chest CT when they're sick, or like someone says they had a pneumonia or something, and then the chest CT looks horrible, and people's like, oh, this is like an infection or something. And then the patient just goes under the radar for a full year and not having symptoms. And when like afterwards, when they have horrible pulmonary hypertension, they do the chest CT and that's exactly the same. So like, how to evaluate the chest CTs when like they are done in the context of like the patient is sick?
I just mentioned earlier, our rule is not, if a patient has an acute event, whatever it is, we would do just regular x-rays. We would wait at least a couple of months to pass after the, and when I say acute event, could be MAS, could be infection, whatever. We would wait 2 months before we repeat high-resolution chest CT.
So, no, that's an excellent point.
Because if you think about, MAS, most of the patients with MAS will have some lung involvement. I remember one patient that I had, actually, interesting story, but anyway, we even managed to get hemophagocytic macrophages from the BAL fluid from that kid. So they all have some lung involvement. So it's caused by MAS, what's by the underlying disease, it's impossible to distinguish. You need to wait until the acute event resolves.
So my question is like when the patients who were seen at a hospital and they did a chest CT or something, like should we have a lower threshold to investigate lung disease on SGI patients who are diagnosed with pneumonias or?
Yeah, that's absolutely. And make sure that the least you can do is to repeat your chest X-ray 2-3 weeks later to make sure that there are no residual changes. Because again, with Grant, we saw quite a few kids were diagnosed with pneumonia, treated with antibiotics, got a little bit better, never repeated chest X-ray, missed the initial stages of lung disease.
Can I add?
Yeah.
Just pointing out, like, we had a cohort of like 5 patients with congenital heart disease that had terrible disease, and their CT was late because of the risk leading the disease. And so there are high risk. It's scary to state with CT, but especially the patients with congenital heart disease.
Good point. Mm-hmm.
Alexei, did you put any protocols in there for echo? Is echocardiogram part of any of your baseline screening?
Well, certainly.
Talk about that.
Yeah, we do echo because many of these patients do develop pulmonary hypertension. Although I have to say that, surprisingly, I remember my very first patient with the very first biopsy. The biopsy showed massive changes in the pulmonary artery, and guess what? The patients did not have pulmonary hypertension. Yeah, it probably should be somewhere in that protocol, correct? Mm-hmm. Paul?
And I guess, Alexei, what's not there is also important because I think you're not advocating lung biopsy and all, which is quite invasive, correct?
Correct. Yeah, that's very clear. So I'm saying that if we pick up a very characteristic pattern on high-resolution chest CT, we do not do biopsy. Unless we are worried about infections, and sometimes we do, then we might consider a BAL scope with a BAL fluid, but certainly not a biopsy. Grant, when was the last time we did a biopsy? Do you remember? Oh, Grant is sleeping. Okay. We haven't done biopsies at all recently.
Although they went on TV. Yeah, we biopsied the first several, right? But then we realized we were seeing the same patterns over and over again, and it wasn't really informing our treatment. So, so we bronch most of the new ones just to make sure that it's not infection. But biopsies, and our team is starting to do more of these bronchoscopic cryo biopsies that are much lower risk, and they've done that on some patients that have a little bit atypical features. Most of those kids end up being able to go home that same day. So,
but that approach is tricky because if you look at the initial stages of the disease, it's very patchy, right? So you really need to get
correct.
Most of the lungs look perfectly fine. You need to get into that patch, and with this transbronchial approach, I don't think.
Yeah, it may not be the.
It's not that helpful. Okay, so yes, and then I think we would like to hear the European perspective on that.
I have a question too.
Just this infection issue is still, it's hard. Like BAL, everyone gets BAL because you always bring that up because they're on immunosuppression, and could there be both? Like there could be lung disease and so on. I think that's always a dilemma.
So Alexei, and what about the follow-up? How frequently do you repeat the CT?
Yeah, we just discussed that with Paul, right? So our
No, yeah.
Yeah, we just discussed that. If it's a CT, so our rule until recently was once a year. Paul convinced that it's not aggressive enough. Lauren is suggesting the same thing, so it probably should be at least every 6 months.
3 months after the first one,
And then?
Then make it up.
Yeah, okay.
May I make a point as a parent? So just, I think this, we've had this discussions when during the parent-family conferences, and yes, parents are very okay with like a lung CT for screening. I think once if you are diagnosed and there needs to be follow-up, we had both CTs and bronchoscopies done, and I felt that the bronchoscopies were, in my opinion, better. Because I didn't want repeat CTs, but also I felt like after the CT, often nobody was really willing to give me an answer as to what's going on. Because sometimes they were like, well, it's looking a little bit worse, but it might be infection. I was like, but whereas, because it had been diagnosed as pulmonary alveolar proteinosis, so like we would talk with the physician who saw the fluid, and then they would tell us. So it just felt like we got a little bit more information from it. So that's kind of my parent perspective.
So we would like to hear your perspective now. Yes.
So it's quite difficult because in the European registry we don't have collected data regarding the follow-up. As I showed yesterday, almost all the patients receive a high-resolution CT at the time of diagnosis, but we don't know actually nothing about the timing and the follow-up. The BAL was performed in less than half of the patient, and the biopsy was done in a very small number of patients. So, the data are very heterogeneous. The cohort is quite heterogeneous. We started to collect the data 3 years ago, and probably we need to look again to add some information based on the new data and new suggestion.
Maybe rank the risk factors.
The risk factors, yeah, exactly. Yes, I agree.
Was suggesting, because they're not the same.
Yeah, and when we start to collect the data, we didn't know the risk factors, so we have to check again, to ask the colleagues again more information and to understand better how they do and they follow these patients. But it's difficult because the management in different countries in Europe is very different. So particularly from Eastern and West Europe, but we'll see. I can say that here in Rome, even we have a small cohort of patients, we follow them very similar. So we perform actually the CT at baseline in patients who had the high risk factors, and in addition to the pulse oximetry and the functional test, pulmonary test, and we repeat the CT every 6 months actually at this moment. Yes.
In Japan, we usually use serum KL6 levels to detect interstitial pneumonia. So I recommend you to check serum KL6.
KL6. Do we have a date on KL6 on all?
Just to update those in the audience, KL6 is a specific antigen of a myoactive protein called MUC1 that has a decent literature in sort of pulmonary damage literature as a biomarker of lung disease. And so the hope among the lung people is to have something akin to an AST or ALT for lung damage. And the KL6 has been posited, but I don't know if we have any real pulmonologists. I think there are challenges with specificity just because, one, it is a very specific antigen, and two, the protein it's measuring is massive, and so how other antigens that protein behave has been a little funny.
But it's increased in several interstitial lung diseases.
For sure.
Of different sources.
It's not specific.
Well, it's not specific, but it may be useful.
For this setting, it's fine.
I think it might be.
Yeah, we're looking at that. Actually, a fellow, one of Randy's fellows is working with me on our CARA cohort, looking at KL6 levels, and that they're definitely higher than systemic GA patients who don't have lung disease. But and she's looking to see whether that correlates with anything, disease severity or progression. It's high in the range of what you see in primary PAP.
I'll actually anecdotally add that other kids who get lung disease in our cohorts, we follow KL6, and it actually tracks with disease. So it may be valuable for these kids as well.
Is it clinically available?
Yes.
Repeat the question.
Oh, the question was, is it clinically available? And the answer is yes.
This is not as detailed as others. It's really just more about screening and monitoring, and it's not just lung disease. So so nothing about treatment here, just at diagnosis, pretty much for all patients, we want to follow their normalization of T-cell activation markers, whether CXCL9 or soluble IL-2. We do try to look for this IL-18 nadir. We do try to get HLA-DRB1 typing. It's easier to do inpatient than outpatient. And we get a baseline chest X-ray on everybody. We don't get a baseline CT on everybody, but if they're high risk, using basically all the same things that others have talked about, or they have persistent disease after about a month, or they flare, then everybody gets a CT, we send them to pulmonology, we have them get an echo, and then we have them do whatever functional test that we can. We haven't done the fit to fly test, that's an interesting one. We do either the 2 or 3 or the 6-minute walk with the pulse ox on as a sort of test. We've done a few overnight pulse oxes. I don't know that that's been management changing. And then we have other pathways for infection prophylaxis and for bone health and for HLH that we just sort of refer to. And then following that, it really is basically kind of an individual decision, although I think that we probably are getting CTs on patients with lung disease more than yearly, between 3 and 6 months. And as mentioned yesterday, we have a fairly low threshold for referring to our transplant group for just an initial eval.
So what Lauren was trying to say is that our referral used risk factors was 1 instead of 3 of Cincinnati, so very similar approach. But. I think there's still individual approaches in the clinic too. I'm not sure, we're definitely following, but work with our pulmonary colleagues very closely, and we rely on her, recommendations. Like I don't have some patients, if there's really big stability and so on, they may not get the CTs every 6 months, because it's scheduled, but some may get every 4 months. And there are sometimes intercurrent infections that then it may change the CT. So I think just changes.
Can I ask something about the functional test? So in young children, it's very difficult to perform even the 6-minute walk test. We have now trying in the Netherlands, we cycle a lot. Yeah. We do cycle tests from the age of 3 or 4. Yeah. With fixed ECG and saturation measurements, and it really looks promising. At least you can measure quite okay how intense the activity is, and you can track really good and dissect the cardiac and the pulmonary function.
Yeah, exactly.
So we have not done that much. We have only 1 child with ILD. So do you have any data on the performance of 3-minute walking test in patients with lung disease? Do you see that on a 3-minute walking test, or is it just?
Our pulmonary does 3-minute walk test, 3 or 6.
But do you see it affected
I'm
in
not
children?
Sure. I have to ask. What I do in the clinic is actually I ask them to run and then they come back. I just check their heart rate, see how they're breathing and so on. It's just sometimes subtle things that can help you too in the clinic. Yeah.
Rand, do you see abnormalities in the 3-minute walking test? Even in affected children, because what do you then see? What findings?
Yeah, so the actual distance walked is hard because it's impacted by a lot of things such as strength and conditioning. The biggest thing is what happens with their oxygen levels. If when their heart rate's getting up, do they desat? If they're desatting more, that seems to correlate with progression of lung disease.
I thought you were asking something else. Yes, that is what they follow, like oxygen.
Yeah, because they report out all the distance and the things, but
that in a moving child.
yeah. You got to just run after them with a little pulse ox. It's a 6-minute walk test for me, too. Of distance, yeah, so they have normative values for, but again, those are on healthy children who don't have arthritis and are not deconditioned by chronic disease, which is why I don't find those very helpful. The biggest thing is if they're getting their heart rate up, do they desat? Yeah, exactly. She said it can trend it over time.
Just another quick question on monitoring. I think as Grant said before, one challenge is to discriminate how much is damage, how much is inflammation. So any clue for that from your experience, despite activity, disease markers of disease activity in general, but other features from the CT or / other?
Yeah, that's hard because on the CT it's really hard to differentiate what's fibrosis versus what's interstitial inflammation. This is, I think, where biomarkers like KL6, like some of these chemokines that have been associated with this disease could be helpful to maybe track, and even some things that are fibrotic markers, what is reflecting of ongoing inflammation in the lungs versus not. And then the hope, obviously, is then if you can control that ongoing inflammation, then outcomes are better and not be guided by a scary-looking CT if the inflammation is quiet.
Yes. So what's the next step?
Can I make a proposal? I mean, there are subtle differences here, but it wouldn't be nice if we had a unique and unified screening and monitoring protocol for lung disease. And I think you guys who have these 3 protocols, which are pretty similar, should actually try to stick together and make it one and disseminate it. That would be in my to-do list. As you have probably a larger experience than most of us, and you should give it a try.
I think definitely, even for the red flags, I think there was a discussion to grade them, or I think that's, I agree with that too. And even doing that often CTs, for example, I don't know like what is the risk of exposure to CT benefits and so on. We should probably have some idea about that too, right? I mean, still a...
I think the red flags is the less difficult thing.
So, Lauren, could you repeat the differences, underlie the differences between your protocol and ours one more time? We didn't hear you very well when you said that.
Oh, I think what's remarkable is how similar it is. And I think the main difference is that we refer at 1 risk factor and you're referring at 3. Did you hear me that time?
Yeah. So that's easy to reconcile, right? And then when you need to get the CHOP people on board.
But I think the order of those red flags may be important. You know, like again, I'm trying to see if we can minimize the chest CT exposure and like how often, and like we really, because our pulmonologist we have the luxury, she's so nice, and I almost refer everyone if I'm just like very little, even if like half a red flag, we do that, but it's still important too.
If we're making a consensus of recommendations, should we also get pulmonologists involved? Because they are going to be the people who are going to get the referrals. So I think it's easier from, like in Boston, they talk to their pulmonologists, but if we're making a consensus that people everywhere are going to end up following, it might be helpful to also hear from pulmonologists from other places.
Yeah, I think Rashmi and we were discussing about that, and I know Scott mentioned that too. Yeah, I think that's.
I believe the risk factor red flags is mostly for us, rather than the pneumologists. They would help in the modalities of screening and monitoring, maybe, and they will be very helpful there. But the red flags, it's us.
Yeah, I was about to say the same thing. I'm impressed that your pulmonologists know so much about it. Our ones are clueless. When we say, well, it's up to you, Paul, you tell us what to do. So I don't think really many respiratory physicians have clocked onto this.
Yeah, I think that's really important. Even in the same program, like we have certain people, like I see more things sometimes on the PFTs and so on. Then I always ask who is specialized. It's really important.
There are also some characteristics that are baseline and don't vary with time, obviously. I wondered, does age at onset predict long-term, or is it just in the moment? So if you're under 2, is that a baseline characteristics for any development of the future, any future development of LD, or is it only age under 2 at the time? Yeah, but do they always get extra, are they always considered to be in that high-risk category, or once they've never had lung disease and now they're 5, does that onset at age 2 still predict it? I don't think so, unless they've had an otherwise refractory course and there's other things, but I'll just throw out there that we should, if this is going to be a guideline, we should also differentiate those baseline factors from other ongoing factors that might move or change with time, so that we're creating awareness around what kind of ongoing screening people should have. Say, the people not in this group, right? We should make sure that we differentiate a little from baseline characteristics versus ongoing ones.
I think the issue you may find is that most people don't recognize the lung disease. So you say they're 5, they haven't got lung disease. Well, they may have had a smouldering mass but didn't tick all the boxes. So the uninitiated will say, well, they've never had mass and therefore we're not going to do anything. So I think that the early onset with overt mass, it's clear cut. Early onset, no mass, well, are they so severe? Who knows?
I must say, like clinically, I had a few patients. I think, when you look at clubbing, like I see a lot of clubbing in patients who had a presentation 10 years ago, younger than age 2. I do send them, and our pulmonologist, again, she also get concerned, follow them with PFTs and so on. It's probably over rate of clubbing because it doesn't change, and then sometimes though there's like obstructive problem which you don't expect. So like I think some changes there in some patients that I just don't know. Like we can say, I guess we can say clinically follow if there's any sign of you're concerned. You should have a low threshold.